Hi, my name is Caitlin, a bio major in my third year at USF, and I want to become a doctor and I want to go into pediatrics.
Fantastic. Thank you. Lebing.
Hi, I'm Ebong. I recently graduated from UC Berkeley, and I've kind of been doing a few internships on and off. I worked at UC Berkeley, then I went to Mexico City and worked at an eye clinic there, and now I'm working in the Department of Infectious Disease at San Francisco General Hospital, and I recently got into medical school at USC.
Congratulations, Lebing.
Thank you.
Yay!
Thanks.
All right, Sophie and Dominique.
Hi, I'm Dominique. I'm a senior at UC Berkeley. I'm majoring in foreign energy and development, and I'm hoping after this to either go into a career in disaster relief, microfinance, or possibly become an officer in the Army. So we'll see.
Oh, I'm Sophie, and I'm also a fourth year too, but I'm an econ major, and I'm going, well, right now I am through med, and in the process of applying to med school. So we'll see how that turns out, but, or at least for a while I thought I wanted to become a physician. I still think I do, but I might want to work a lot with international policy as well. So we'll see where that leads me. So, yeah.
Awesome. Thank you. And finally, Kate.
Hi, everyone. I graduated at USF with a degree in psychology. Right now I'm working as a case manager with the elderly. And I will be attending chiropractic school in January. And I was thinking of going international with chiropractic along with local research and whatnot.
Awesome. Thank you, Kate. Awesome. So I'm now going to go ahead and do a brief introduction to Christy and then let her complete the introduction. Things I just want to get out there. She can talk, Christy can talk as long as you want to, but I do have to end this thing at very close to 8 o'clock so we have time for our next speaker. I'm going to ask all the attendees to, while Christy's talking, to please put your computer on mute so that the background noises won't come in there. Perfect. Awesome. You guys are great. so that way when Christy talks, you guys can all hear her. Christy, hopefully if we can match the time, we'll get a little time in there for Q&A as well too. So really quick intro here to Christy. Christy, I met her online. She reached out to me. She's a wonderful individual. She has a public health background from Johns Hopkins, if I'm not mistaken. She has extensive experience with Epic Medical Systems, which is probably the largest electronic medical record system, definitely United States, but could be also in the world, I'm thinking. Very good extensive experience with Stanford's medical system as well too, and has an amazing story of her mission in international healthcare. So without further ado, I'm going to hand the floor over to you, Christy.
Thank you. Can everyone hear me okay? Okay, great. Well, I am excited to talk to you guys. So, Francis, thank you for the opportunity to get in front of very smart people again. I'm listening to all your stories and your ambitions, and you guys are going to do some really great things. So it's an honor and a privilege to talk with you tonight. I'll try to keep my formal talking short so that I can answer questions. I actually took down notes on all of you as you were talking and what your interests are and your backgrounds and everything. So part of you may be wondering, why am I here? I'm big on mentorship. I'm big on identifying smart young minds because I'm passionate about healthcare and that we need a lot of fresh blood in the mix and in the industry. And I use that very broadly. So that's domestic, that's overseas, that's in industrialized, it's in development settings. And I really strongly believe that the millennial generation is going to make huge changes. path for the better, and we certainly have our work carved out for us. So I guess I can start. I can give you a little bit of background on myself. I have an eclectic background, and I will kind of tie that into an overall message that I gave the last group that I spoke with, and then hopefully open it up for any questions that you have. I'd also like to offer up, before I forget, I'll have Francis send out my information to the group. Well, we're doing some background noise. Did somebody present anybody on mute?
Oh, let's see.
Sounds like someone's right next to the street. There we go. Thank you.
Okay.
I think that one of the biggest things that I've learned in my career is that there's no right way to get to where you need to be. And so some of the questions that a lot of you are probably grappling with in terms of what am I doing, what are the right next steps, in my experience, and some of the most successful people that I know have taken very creative routes to get to where they are today. And so hopefully we can talk a little bit more about that. But wanted to talk with you before I get into my background about some ways that I find inspiration and kind of what drives me. And I consider myself still very early on in my career. Full disclosure, I graduated undergrad in fall of 2004. And I just finished my graduate studies in December. So I was in your shoes, a lot of your shoes, not that long ago. But I distinctly remember actually I think I was still in school. I was in undergrad. I was at University of Wisconsin studying global security and political science. And I was visiting friends in Haiti. I know it sounds like a lot of you have international experience. You've kind of traveled around quite a bit. And I was about 21, 22 years old. I was traveling in Haiti with friends of mine. And my friends down there, it was a family friend. The mother actually owns and runs an orphanage. And it was a unique experience because I would go down there and bring supplies and, before I would go in for a couple weeks on the holidays, get a bunch of medical supplies together, get different, linens and things for the orphanage. And it was not a solely humanitarian act as much as it was just kind of the right thing to do. And I would get these laundry lists from my friends saying, we need all these supplies and all these things, so whatever you can bring. So it was an interesting experience one day. If any of you have ever traveled to the developing world, we're eating outside. The family house is on a compound. There's actually 2 homes on the compound surrounded by walls, about 8-foot walls with barbed wire at the top. And the barbed wire is for security reasons. Haiti is, I guess, arguably called a failed state. It's a very volatile country, extraordinary poverty, highest poverty rates in the Western Hemisphere for sure, and all the challenges in the healthcare context that go along with that, such as HIV/AIDS, morbidity, and mortality, which we've been trying to get under control, and then compound that with natural disasters and a lot of the stuff you hear on the news politically. And there's a lot of challenges. So my friend runs an orphanage in Port-au-Prince, actually in a suburb of Thionville, and works with French adoption agencies to pair French parents looking to bring home children with Haitian orphans. I use the term orphans loosely because politically and socioeconomically in Haiti, that could even include a child whose parents simply dropped them off because they couldn't care for them. They couldn't afford to care for them, and there's no government infrastructure to care for them. So we're sitting outside one day after lunch, and we hear all this commotion, and they have house staff, they have maids and stuff that work at the house, and they come running, and they say, there's a baby. And we said, what do you mean there's a baby? And they said, there's a baby. They just left a baby by the gate, like on the doorstep by where this big gate opens up to get into the compound. So we go running, and there is a baby, swaddled up. It's like something out of a storybook, laying by the gate. But it's a preemie. It's a premature baby, just born, extremely underweight. Could not have been more than maybe 4 pounds. And so this was my first time being there when I'd actually seen an intake type situation of, okay, so someone drops off this baby and there's no one around, and you're what do you do? I mean, in the U.S., what would you do? You don't have papers for it. It's not yours? What do you? There's infrastructure. There's nonprofits. There's a legal system that takes care of this, and in Haiti, that's just not the case. So the first thing that we do is my friend, she's about 50, in her mid 50s. She picks up the baby and she tells me like, go catch whoever left the baby. Try to catch them. And I was like, well, what's going on here? You know, so fill me in. And it's rapid Creole and rapid French, and I get little pieces of everything. And ultimately, the baby had been dropped off by a sister or a cousin and a friend of the mother. And they were from a place in Port-au-Prince called Bel Air. And Bel Air is one of the world's largest, most notorious slums. It's just next to the Port-au-Prince airport. It is one of the most dangerous places on earth. Even the United Nations peacekeeping forces, they don't occupy Bel Air. They don't go in there. It's too dangerous. And the mother had probably been working to make some cash or been raped and was impregnated and couldn't care for the baby. So the first thing that we do is she gets the girls, they're young girls, they're probably 14, maybe 15, and we all pile in the Land Rover and we're bumbling through the streets because we have to go to the lab. And so I'm trying to get context on this, and I'll come full circle with where all this is going. And so, well, what are we doing? Why are we going to the lab? I mean, the baby's very small. I'm trying to piece everything together, and she's like, well, we need to go get the child tested. And we're like, well, okay, tested for what? Ultimately, what it was is they have limited resources to care for children at the orphanage. And so if the baby's not a healthy baby that's viable for adoption, they won't take it. And they'll send it to a nonprofit that basically cares for sick children that they don't think they'll ever find adopted parents for. So I'm trying to wrap my American, Western, privileged world head around this whole thing and the injustice of it all. And I've been to Haiti many times. I've traveled quite a few places around the world, and I'd seen and heard these things, but seeing this 4-pound child right in front of me and thinking, wait, so we're actually going to take this baby to the lab, and if it's not healthy by your lab standards, we're going to send it away to a house somewhere to die. Okay, don't be emotional. It's not about you. Just figure out, try to see how you can contribute to the situation. So anyways, we got the baby tested, and we're kind of sitting there. It's a tense situation. Full-blown SIDA, full-blown AIDS, full-blown syphilis, at least one strain of hepatitis, just sick. And for many of you with a clinical exposure know, it's very difficult to have a newborn with full-blown AIDS. You can be born HIV positive, but the mother must have been extremely sick to have a child who had full-blown AIDS. And so we left the baby there, and they take the baby to an American woman who runs a home and cares for these children that can't be put up for adoption. So I had only seen all the glorious parts of the orphanage before, like parents coming to meet their children in this extraordinary joy when you see people who want nothing more than to have a family, and you see children who want nothing more than parents who can care for them. And this experience, and I came from a healthcare background. I was working in international health office as an undergrad, doing development work, exchange with Vietnam, and it was jarring and jolting to me that I had to put my emotional response aside, and all I thought is I have to wrap my head around what this means. Like, how can we solve a problem like this? And so, anyways, long story short, that was a defining moment for me in terms of what am I doing with my life? What are the bigger picture questions here? Because at that point, there was nothing I could do. There was no amount of love or money that I could throw at the situation to help that child. It's a systematic and it's an economic problem. And so the interest in healthcare was there. And I think for me at that moment, I had this awakening that healthcare is so much more than injections and clinical medicine and medications. And it really made me, the more that I dug into it, and of course I asked my friend millions of questions about, what do you do in this situation? Well, why can't you take, and she's like, no, listen, the resources are limited. We need to use our resources efficiently. So if we only have this amount of medication and we know that we need 90% of it to treat a child to get them fully healthy, as opposed to if we split it down the middle and neither child gets completely healthy, then those are judgment calls we need to make. And I'm just thinking, oh my gosh, okay, what am I going to do with my life? Do I want to go into development? Do I want to be a physician? Do I want to, there's so many things. And I now am in IT. I'm in health IT. And I kind of want to talk to you all a little bit about where I'm at in my journey, where I'm hoping to go, and kind of some of the perspectives that I've gained along the way. So that's I tell you that story because I think that it's something that when I was in your shoes and when I was actually a lot of your age, it was something that struck me so strongly, especially when I was trying to figure out what am I doing, what do I want to do. You know, I'd say, oh, I want to be a physician, but do I really want to be a physician? And how much do I really know about it? Or I want to do research, but what does that mean? Or I'm interested in pediatrics, but I want to impact things on a bigger scale. And so maybe I'll kind of backtrack now and give you some context on what I've done since then. So my eye-opening moment was that I really realized that to impact a situation like that and to really make a difference, I couldn't just study one isolated thing. So when I grew up, like a lot of you, your parents are probably asking, oh, what are you going to be when you grow up? You're going to be a doctor, you're going to be a lawyer, you're going to be a fireman. Except that the world isn't really divided into doctors and lawyers and firemen anymore. You can become an MD and you can be doing hundreds of different job functions. You can be in the business function, you can work in IT. They need physicians that serve on policy committees in Washington. There's so many things. For me, I have no clinical background and my entire career is healthcare. And so when Francis and I were talking and sharing notes and sharing stories, we just really we were geeking out a little bit on healthcare and how we have this generation of great thinkers coming right now that is thinking unlike any other generation before because we have information at our fingertips, unlike anyone has before. You guys know how our parents' generation handles iPhones and texting and stuff like that, and it's just wild. My dad texted me some acronym the other day. I think it was TMI, and I think I looked at it for my phone down, but that's enough for that. But so really, I think to go full circle, my passion is in healthcare, but looking at it in so much of a bigger way than the world I grew up in, which was, okay, be a doctor, be a lawyer, be a teacher. And so after I finished undergrad, I got my undergrad was in political science and global security, University of Wisconsin. I worked in the Office of International Health there for the entire 3 years that I was there and did a lot of development exchange work. So some of the things that we did were exchange with Vietnam. So in Vietnam, they have some great transplant surgeons. A lot were educated abroad, came back home to work, but they have no organ harvesting infrastructure. So in the United States, if someone's in a car crash, you have it on your driver's license. It says if you're an organ donor, or in the hospital, you fill out advanced directives, things like that. In Vietnam, they didn't have such a thing. So my boss would actually, a couple times a year, go over there, and she would actually bring a refrigerated briefcase of human retinas for transplant surgery. So she'd go through customs and have to have all this executive clearance because she'd have this briefcase of eyeballs, of real living tissue eyeballs. And she'd bring them over for transplant for people who need eye transplants. She also brought cow ove, so eggs from American cows that were genetically engineered to produce high nutrient milk for child development. Somebody said you had an interest in pediatrics, and so it was interesting that we'd have to work with pediatricians and with geneticists and with agricultural economists and animal scientists to kind of solve some of these problems with child development. That was my undergrad experience. Coming out of undergrad, I graduated early, kind of on accident, and realized I need health insurance. So that was my first personal exposure to, wow, you're an adult and you're unemployed and you have an undergraduate degree in political science. What are you going to do next? So I actually got recruited by Epic Systems. It is probably the largest electronic medical record software vendor in the country, arguably in the world, or it's on its way there. 1 in 4 patients in the United States is in Epic. It's not just a plug-and-play system. You engineer it to do everything. It's a capture of data. You can do everything from getting in front of all women age 50 plus who have not had a mammogram in the last X number of years to prompt the physician to make sure that patient gets a mammogram. All kinds of decision support and fantastic clinical guidelines, as well as billing and revenue. So for those of you with finance backgrounds and interests on the call. And working at Epic, I did project management implementation. So I was 22 years old and overseeing $3 million software implementations. And I did Stanford's project from '06 to '08 and learning everything about how a hospital operates and kind of the tech side of the business, which is really driving a lot of things. I think one thing, if you all haven't discovered already, that you will see is that it's interestingly enough, technology is driving a lot of the changes as opposed to the clinical medicine needing to drive a lot of the changes or the patient demand. And so that we're really using that to institute some of the things that need to get instituted with health reform. After Epic, I went and did management consulting for about 2 years in the operational space. So I got a lot of experience with executives in hospital administration. Management consulting is a great starting point, especially right out of school, to get professional experience, quantitative analysis skills, understanding how to present, how to articulate ideas, and really come into an abstract situation where you're not the expert, but you know how to ask the right questions and figure things out. And after that, I actually had an opportunity to go to independent. So I incorporated in 2009 and have been private. I have been independently consulting for the last 3 years. A few months in, I actually started my master's in public health and my MBA at Johns Hopkins. It was an incredible experience. Served as president of the International Health Society while I was there. We did all kinds of work with exposing people to international development initiatives, major speakers, key players in the industry, everything from hosting Child Health Week that brought together premier pediatricians into discussion forums. We had financial discussions on funding healthcare and cost constraints and the economics of medicine, which is a hot field. It's big and it's only going to get bigger. All kinds of fun stuff. And also while I was at Hopkins, I actually had an opportunity to first consult and then serve full time in Washington for the Office of the National Coordinator. It's the health IT branch of the federal government. And they're doing some very cool things. They've brought in a lot of key players from the private sector, which is a big deal in the government, especially because they generally operate very differently. And they're really pushing adoption of technology in hospitals and clinics around the country. That being said, since graduating, I'm now living in San Francisco. Great area. My husband's work actually brought us out there. He's working for Apple. And I'm currently consulting down at Cedars-Sinai in Beverly Hills, which is where I am right now, and helping them with governance, organizational management, organizational structure, and all those things. So you all are probably wondering, okay, what does all of this have to do with the story that we started out with? And it's a very great and logical question. And so I've thought a lot about that myself. And I've talked to a lot of friends in development, kind of living all over the world, a lot of them in Washington, a lot doing field work. And one thing that for me, realized in my journey was I have specific goals. I need to develop a skill set before I can go out in the field and really have something to offer. I've had that exposure in my personal life. I've been part of international student organizations, traveled a ton, but I need to have something to offer. I can't go to my friend's house and help her run her orphanage more efficiently if I don't understand the legal framework around it. I can't, provide any clinical services if I'm not a clinician. So you kind of get where I'm going with that. And so my big decision was, do I stay in the domestic space? Do I expand internationally? And for me personally, I thought, okay, well, I'm going to develop the skill set now, and then ultimately, I've already got some things kind of in the works that I've been looking at, but ultimately I'd like to transition into more of a development setting using the skills that I've acquired to analyze resource constraint problems. So one of the big things I focused on at Hopkins was, how do you take limited resources, limited medications, you have limited funding, you name it, and actually find the most intelligent way to use those things. So even in the U.S. right now, it's one of the biggest things we're struggling with, right, when it comes to health reform, is we have all of these moving parts, and no one in the industry, very few people in the industry really understand everything that's going on. If you ask anyone in Washington, especially the most educated and experienced people, when it comes to health reform, who do the American public listen to? The first thing that comes to mind is, well, it's healthcare. I'm going to listen to my doctor. Let me ask you all a question. How many days of business, industry, or technology training do physicians get in medical school or residency? 0. They don't get any. It's all clinical medicine, as it should be, because you're becoming a clinician. The challenge with that, and why I'm super excited to hear some of you looking at like MD, MBA tracks and healthcare finance and all kinds of things, is that we need people that have an integrated background from multiple areas of industry. So not just, we don't have to just become a doctor or a teacher or a lawyer. We can become a pediatrician who has an interest in health informatics and using data to drive better patient care. We need the finance person that serves on hospital administration that says, you know what, yes, patient care is our number one priority, but if we're not able to sustain ourselves financially, we won't be delivering any patient care. Or if we can get to such a great point financially, maybe we can start offering charity care programs to address some of the challenges that our patients are needing. I was actually talking to the CMIO, the Chief Medical Information Officer at Stanford, on Tuesday, a week ago, today, about some of the initiatives they're doing at Stanford. They're taking all the data that they're capturing in their EMRs, and they're working directly with their physicians, their nurses, their hospital administrators, informaticists, and even population health folks. They're partnering with the engineering folks in Stanford engineering professors to break down and identify financially with some of our patient populations what's really going on here. What's causing, say, for example, in cardiology, high readmission rates, which cause severe negative patient outcomes, as well as difficult financial situations. And what they found is that in healthcare, we love throwing money at problems. We love throwing interventions. You know what? All these cardiology patients, which is I think it's the number 1 or number 2 chronic disease challenge in the U.S., all these cardiology patients, they're coming back here because we need to do follow-up phone calls. So we're going to call them, and we're going to remind them of how to take care of themselves after they leave. Okay, yeah, that's good. We made an intervention. It's not founded on anything. There's no real substantive data behind it. What they found by doing this smart analysis and having all these minds from fantastic different backgrounds in the room is they actually found that the patients with the highest readmissions rates were coming from the lowest socioeconomic backgrounds. And that the challenges they had there were a few things. It was reading level, so ability to understand aftercare discharge instructions. It was financial ability to afford medications and to be able to afford them consistently, so they weren't going off of their blood pressure medication. They weren't doing things financially that had negative repercussions on their health. They were actually able to implement interventions based on all this data analysis and clinical minds, IT minds, research minds, engineering minds, all in the room, and doing some absolutely very, very cool stuff that's going to really change the face of how medicine and how healthcare is delivered in the country. So that's kind of my big picture story, my big spiel. I know that we only have about 15, 20 minutes left, and I do want to offer up my information to you guys. If you want to, we can schedule calls offline, or whatever you want. I think, Francis, I don't even know if I told you, I've talked to about 4 or 5 people one-on-one since the last talk. And I've even been connecting people with some people I think they have mutual interest in, but that is my long rambling. I've been talking way too much, and I'm kind of uncomfortable hearing myself speak. So I'd like to open it up for questions, and if there is anything that you guys have questions about, or things that you're interested in, or anything that you think I might be able to help with, I'd love to help.
Thanks, Christy. I think you're going to have about probably 8 more new friends coming aboard now. So, yep, you guys, it's open floor for any questions right now. And don't forget to unmute yourself when you ask a question. Yes, LeBang. But you need to unmute yourself. Okay.
Okay. So I had a question. I actually had 2 questions, and they're like pretty different, but both were I wanted to get your opinion on both. So my first question is about, what is your opinion on the current Obamacare? What do you think you really like? What do you think needs to be improved? And yeah, any other comments you have on that? And my second question is about, I recently read an article published by the National Institute of Medicine on taking kind of different strengths from different industries and applying it to healthcare. So, for example, using Toyota's lean manufacturing and applying it to healthcare systems. But other people argue that that's not possible because healthcare in itself isn't necessarily an industry like everything else. So I was wondering if you had any opinions on that as well. That's all. Thank you.
Those are fantastic questions. So to speak to Obamacare, I'm in the political hot seat. So I gave you guys full disclosure that my undergrad was poli-sci, and I got it from Wisconsin, which is a liberal university. And I did my MPH and MBA at Hopkins, which is the largest recipient of government funding for research in the country. I think they get 20% of all NIH grants in terms of sheer capital. Obamacare, for lack of any other term, and since he kind of endorsed it now after the debates, it's absolutely fantastic in that it's necessary. There was no way. The one thing everyone agreed on is that, the naysayers really had no other solution. The reason is, the way I look at it is, say that you have a private industry and you want it to succeed, like a consumer retail market or something like that. And we have our healthcare industry, and if it's going to be a private industry and it's going to succeed, you know what? Let's give it a boost. Let's carve out the two of the populations that are going to take the most away from our ROI, from our return on investment. Let's carve out the old, because all they do is suck up healthcare resources and they don't pay anything into the pot. And let's carve out the poor, because they wait until they're too sick and then they come in and it's like so much more complicated and expensive. So the old would be Medicare, covered by government, and the poor would be Medicaid, right? And we did that. And we've had that for 40, almost 50 years, and it hasn't worked. And we have a whole lot of folks in the private sector that have been trying to take advantage of this crazy healthcare problem, and then we realize, oh wait, it hasn't worked. And so my opinion is that I think it's a great start. The American public is extremely uneducated about the complexities of the healthcare system. I think one of the biggest challenges we see is that we need to find a way to have market mechanisms that are pushing cost controls on our spending, because we are out of control. For dozens of years, the American healthcare consumer, which is all of us, we don't feel what we have to pay when we consume healthcare products or services. So when we want a new pair of shoes, we have to be smart about it. We have to think about it. We have to plan for it and account for it. And someday these shoes aren't going to fit, or they're going to run out, or they're going to need a new heel. with healthcare, we have a lot of protections in place, so people aren't feeling that, and as a result, the spending for each product and service has gone out of control, as well as the design of our system being fee for service. So physicians are rewarded by doing more tests, more visits with patients. They get paid more. They're not compensated based on quality outcomes. The Accountable Care Organization model, ACOs, as a lot of you have probably heard about, is absolutely the right direction to go in. Kaiser is a shining, beautiful example of what that might look like, hopefully rolled out on a national level someday. So I'm a huge advocate of that. I think the payer side of the industry is going to feel a lot of pinch and a lot of pain. I think that's deliberate, and I think we need to go that route and pass it on to consumers so that we feel the pain a little bit, so we can start shifting how we do things. In terms of the strengths from other industries, that's a great question because we absolutely need brilliant minds from all over the place. Other industries have been able to find great ways to do things, and it's not so sensitive. So, when Toyota has something go on and they make a financial decision, nobody's screaming, rationing, death panels, like, so you're saying the government's only going to pay this much and you're going to kill my grandma. Nobody does that because it's car manufacturing, and car manufacturing generally doesn't kill grandmas.
You are now running on reserve battery power.
Oh, somebody's running on reserve battery power. That's pretty funny. I thought it was mine at first, actually.
Oh, Ada.
So I think that the challenge is partly in how do we educate people on the realities of health, the healthcare industry, and especially the health economy. A great way to do that, if you guys are super geeks like me, is start researching what health systems are like in other countries. It's fascinating and definitely opens your eyes to our arrogant, Americana-centric way of seeing things, because especially you look at like Japan, UK, the Scandinavian countries, yes, they pay a lot in taxes, but by every other indicator under the sun, they are just blowing the smoke out of us. They're killing us. We spend more by landslides with extraordinarily worse outcomes than any other country on earth. So a lot of it's cultural, a lot of it's public education levels around the issue. It's a very complex, very difficult industry to understand. And so I think those are some of the challenges. But why not use, lean supply chain principles from the manufacturing industry? Why not use business process context from engineering side of the house? Ultimately, we don't have time to figure it all out ourselves in healthcare. We don't have time to just say, oh, we're clinicians, we need to figure it out ourselves. No, we're clinicians. We know the body, we know pathology, we know physiology, we know chemistry. But engineers know process engineering, and finance folks understand numbers, and ultimately, we can't afford to ignore those things anymore.
Excellent. Thank you. We have about 10 minutes, a little shy of that, for a few more questions. Anybody? Oh, Ada.
Sorry, I was just wondering, would you recommend going into healthcare management or like management consulting before applying to medical school? Just because I know nowadays a lot of people are taking a year off before going straight in. So what's your take on that? And also, what do you think about the American healthcare system as compared to the Canadian healthcare system?
Great questions. So with regards to taking time off, Francis, you're probably laughing. This is the money question from last time.
Mm-hmm.
The one that I got the most follow-up comments about. I graduated early. I was barely 22, and I started grad school when I was 28, almost 29. So I worked for about 6-7 years, which is a long time. I think that anyone can value from real world experience before getting professional or graduate education. It's not going to hurt you. I think one of the biggest things I hear people saying about going directly into a graduate program or directly into a professional field is two things. One, my parents are putting the heat on me to go do this right now. And 2, I'm afraid if I don't do it right now, then I'm never going to do it. To the first one, I have to say, the parents are probably very smart people. Maybe they have the same fear as you do, which is number 2, that you'll never go. I think that if you're smart and you're driven, and you go into industry and you start working and you start seeing all the challenges and all the problems, having that context and having that experience to draw off of, and then going into an academic setting where you're able to learn those things but actually bring something to the table and have context, it would be like going to college and taking math, taking calculus without ever having been in a math class in the last 4 years. So being able to kind of give you that context and give you something to draw off of, I think is extraordinary. Additionally, it gives you the ability to ask hard questions that other people might just take that information for granted. So with regards to taking time off, if you're driven, if you're hungry, plus in this environment, in this world, it's very difficult outside of some of these Bay Area startups. I know guys, I know. Outside of some of the Facebooks and you can have a bachelor's in or a bachelor's degree in political science and make it rain financially. I think that in general, to succeed in a millennial generation, to be competitive, we're going to need graduate degrees or professional background. With regards to the U.S. versus Canada question, I'm not the world's expert on it, but it's the only thing I think I'll leave you with here is think about the weight and the power that anecdotal evidence carries in terms of information asymmetry. So what I mean by that is you're at Thanksgiving dinner and your uncle's like, yeah, my friend, he had to wait in the line as his heart came out of his mouth and he was dying on the floor of the emergency department in Canada and he didn't get any help for his healthcare problem. Okay, yes, there is anecdotal evidence that all the boutique services and all of the privileges that Americans, expect and take for granted compared to the rest of the world, as much as I love this country, try to, when you hear that anecdotal information about the Canadian system, try to find ways to seek out concrete evidence and concrete facts about how the system is run. Yes, there is rationing to an extent. People often supplement that with private insurance programs and things of that sort, or what they call boutique services up and above what the government delivers. But try not to be swayed by, I guess, less educated and sentimental or sensational sentiments about those contrasts in the system, and do some research of your own. Get online and Google the crap out of it and see what you guys can come up with.
Thank you so much.
Yeah. Got time for one more quick question, and then that'd be it. Anyone else at all? Any quick questions? Dominique?
You go. So I had a more of a development question. We're muted. Can you hear me?
No, I can hear you.
Oh, good. Okay, I had more of a development question. So Trio talks a lot about after the Haitian Revolution, the idea of the erasure of history. That Haiti's history is so interesting and unique, and it really did spur this discussion and this kind of new paradigm regarding the dichotomous thinking that took place before. That somehow the colonized people were inadequate or inferior compared to like the Western colonizer. And we were listening to a graduate student talk about her experience in Haiti and how she still sees that erasure of history, and developing powers coming in and kind of treating the Haitian people, saying that their country is dirty because they can't keep it clean. And she was saying, that there's so many more underlying, institutional problems, and that kind of play a bigger role in this. So what kind of did you see? Is that kind of erasure of history, Haiti's history being rewritten by developed countries? Did you notice that at all when you were there?
That's a fantastic question. I have a lot of friends that could answer this a lot better than me. Friends that are there right now, that have spent a lot of time living there, friends that are from there, ethnic Asians, whatever that actually means. But I think the short answer is yes. So you see that everywhere. You see variations of post-colonial impacts on society, on culture, on all of those things. And I think that the key thing that I would ask you all to take away from it is my uncle is an attorney. He was an attorney in the U.S., just doing regular U.S. JD type of things for a couple decades. Now he's working for Millennium Development Corporation, I think is the name of it. And his entire life's work has been centered around bringing in the institutionalization of legal principles and almost like a constitutionalization of sorts to build everything else off of. So kind of to go to your question, creating infrastructure and building an infrastructure, first you need to start with the basics. So we need to solve the healthcare problems that baby I saw 4 years ago was facing. We need attorneys that understand what legal infrastructure can do for a country and can bring that and work with people on the ground in those countries to develop those systems and those kind of things. Ultimately, it's so funny. We always see the save the starving children commercials, and they don't need our love. They don't need us cradling poor babies. They need us to see that child as an opportunity for economic potential. And the more that we can create a positive feedback cycle for that child to thrive, the better off that everyone will be. And that's actually, I think at the end of the day, that's the only place to start. And so hopefully, I'll wrap up. I know you guys got another call, but hopefully I've maybe opened your minds a little bit. You guys are asking fantastic questions in terms of what there can be done in the healthcare space. I like to play like Stump the Chump. Ask me, we won't do it today, we'll do it another time, but ask any question, any career, any part of the industry. Don't say stuff like pizza man, pizza delivery guy. I think that most professional industries in the developed world today have something to offer the healthcare space. So it's really about finding what makes you tick, what your natural talents are, what you enjoy, and you can apply it all over the map. So without further ado, I would love, Francis, if you could give them my information. If you guys have questions, you want to schedule a follow-up call. I'm in San Francisco most Fridays and some weekends, and I'd be happy to help in any way I can.
Absolutely. I will make sure that I do a mass email for everybody. And we have our next speaker coming up. I realize we actually have an extra space. Christy, if you want, you are welcome to join in on this 8 to 9 talk if you'd like to. Yes?
Thank you. Yeah, I have a follow-up call with a colleague from work, but I might try to move it back. I'm going to see if I can text her.
Okay, no problem. I'll go ahead and invite Dr. Eric Wang. His talk is basically going to be about everything I wish I knew about medicine before I became a doctor. I think you would actually enjoy that, Chris, because there's a few things you said in here that's going to be echoed in his talk. If you can move your call back, I think he's going to be a good connection for you too. All right, I'm going to go ahead and invite him. You guys sit tight. Did you guys enjoy that talk?
Yes.
Awesome. Okay, let me invite Eric. All right. Okay, invited.
Hey, Francis.
Hey, Eric. Awesome. Thank you for joining us today, or tonight. I'm looking forward to this. We just finished a quick talk here with Christy Ebong, who was our first speaker, and she's making a quick call right now to see whether or not she can push a call back to sit in on your talk as well too. She said a few things that definitely echoes everything that I think that, and then more that you're going to add on to what you're going to be talking to the students about tonight. I'm going to do I'm going to ask the students to do a quick intro to themselves, and then I'm going to do a quick intro to you, and then before I do that, let me try something here, okay? I've never tried this before. I'm going to try to share a YouTube video for everyone. Hopefully this does not hang up the whole call. So, let's see what happens, okay? You guys may have seen this. Eric introduced me to this movie. I saw it with a few of the Edge interns. It was amazing. It totally shared so many things that Eric was sharing with me at the Health 2.0 conference. Let me go ahead and try to see if I can get this done, alright? Give me 1 second. Okay. So far, so good.
It don't work. It don't work. We're not. It's just loading.
Alright, I hope this works, guys.
Oh.
The American healthcare system is badly broken.
The present system doesn't work, and it's going to take us down. We need a whole new kind of medicine.
We're in the grip of a very big industry, and it doesn't want to stop making money.
If I spend 5 minutes with you and then put in one of these stents, I probably get paid $1,500. For me to spend 45 minutes with the patient to try to figure out what their true problem is, probably get paid $15. It's a completely irrational system.
We don't have a healthcare system in this country. We have a disease management system.
We're spending almost twice as much in America as any other country on earth, but our lifespan isn't even in the top 20.
30,000 Medicare recipients die each year from care they didn't need. That's the equivalent of a jumbo jet crashing every single week. If the aviation industry killed as many people, we'd be up in arms.
The administration pays you based on how many patients you see. All right, who's next? If you try and buck the system, someone says, what can we do to get your productivity up? I'm not interested in getting my productivity up. I'm interested in helping patients.
We're seeing the military just being a microcosm of the problem society's having.
Soldiers' use of prescription drugs has tripled in the past 5 years.
Medications I was on.
Only by accepting that the American healthcare system is badly broken will we be able to seek out the escape fires, the potential solutions. There are answers.
One company has figured out how to lower healthcare costs by more than 40%.
We provide incentives for people to engage in healthier behaviors.
The Army Surgeon General directed that we establish the Pain Management Task Force to take a look at alternatives to narcotics.
I was skeptical, so skeptical.
I've gotten a lot of inspiration, a different perspective. There's a different way of doing things that is possible.
If I think about what healthcare could be like, it would have a lot more care in it.
The healthcare system is unsustainable. We're really mortgaging the future. It's not just the health of healthcare. We're talking about the health of the nation.
Okay, so that kind of sets the whole tone for this next talk here. I'm going to ask the students to please, and also one of our last guest speakers to introduce themselves. About 1 minute, and then I'll do a quick intro to Eric, and then we will start to talk. Ada, once again, please introduce yourself if you'd like.
Should I introduce? Okay. Hi, my name is Ada. I'm a second year at UC Berkeley, hoping to double major in public health and integrative bio. Yeah, I'm really interested in going into dermatology as well as getting my MD MBA and hopefully going into hospital administration after practicing for a few years. Yeah, so I'm really interested in working with business and health right now, and I've definitely had a lot of great experiences through Francis. So yeah, I'm really looking forward to the lecture.
Thank you, Ada. Alan?
Hello?
Yep, I can hear you.
Hi. Okay. My name's Alan, and I just graduated this past August with a degree in economics. I'm hoping to get into healthcare administration and healthcare in general on the finance side, so healthcare insurance and stuff like that. And I want to make a change in healthcare.
Awesome. Thank you, Alan. Caitlin? Angela?
Hi, my name is Angela. I'm a junior at USF bio major. I'm interested in doing research once I graduate especially into biotech.
Hi, my name's Caitlin. I'm also majoring in biology, and I am in my third year at USF, and I like to become a doctor and go into pediatrics.
Okay. Christy, our last speaker. A quick intro to Eric.
There we go. Can you hear me?
Yep.
All right. Hi, I'm Christy. I am in health IT, particularly in the EMR implementation and governance space.
Awesome. Lebing.
Hi, I'm Lu Bing. I'm a recent UC Berkeley graduate. I majored in bioengineering, so I've kind of the background and love for inventing devices and stuff like that. But I recently got into medical school, so I'm going to go be a doctor, and hopefully I can kind of bridge the two. And I also have an interest in international medicine and policy, so I'm kind of everywhere.
Awesome. Thank you. Sophie and Dominique.
Hi, I'm Dominique. I'm a senior at UC Berkeley and majoring in philanthropy and development. And I'm really interested in some kind of either disaster relief, definitely work in the developing world, maybe microfinance. We'll see.
Hi, I'm Sophie, and I'm also a fourth year. Did you say? Yeah. Oh, okay. Yeah, I'm also a fourth year at UC Berkeley, and I'm an econ major as well. I'm headed towards the pre-med route, or I guess med school. I'm actually in a process of applying to a few, but I'm still kind of in between whether I want to, pursue that whole clinical route, or if I want to go into MPH. But at the same time, we've covered that healthcare is very broad, very, very broad. I guess entity. So I don't know. We'll see. And I do. I would like to work with international policy, healthcare policy, and stuff like that. So that's it, I guess.
Great. Thank you. And Kate. Oh, and you gotta unmute yourself, Kate.
Hi, can you hear me?
Yes.
Okay, so I graduated with a psych degree at USF, and I am currently working as a case manager with the elderly around San Francisco. And I actually applied to a bunch of DO schools that Francis graciously helped me on. And as I was applying, I was thinking what I really wanted to do, and I was really into, since I worked with the elderly, I was into psychiatry and in that realm. And I was wondering, if I was in psychiatry, basically the patients or the clients that I saw were basically cocktails medications that I didn't want to be just prescribing that, or it was research. So I got into chiropractic, and I am actually gonna attend chiropractic in January, and I just want to explore in the realm of more prevention and anything to basically make chiropractic more credible, because it seems like it's not as credible in the mainstream of, medicine and healthcare. So I just want to go into that. So.
All right, fantastic. Now a quick intro to Eric. I met Eric at the last Health 2.0 conference, which Sophie did a wonderful job of helping us organize with her registration skills. Thank you very much, Sophie. I learned that Dr. Wang here is a radiologist. He's a Harvard grad, UCLA Medical School, and very successful in his practice. But it shared with me some amazing insights that he wished he knew about his journey as he went through medical school and becoming a doctor, that he would love to share with the future generations about how they can prepare and more get insight about what they're about to embark on. So, like before, please mute your microphone so that there'll be no background noise. And take it away, Eric.
All right, so when Francis originally approached me about this, I mean, I didn't really have anything specifically planned out. I think, I could talk about a little bit about what I wanted to do in medicine. I started off, I think I've been wanting to be a doctor pretty much my whole life. My parents were both, they're engineers, they're scientists. I've always been heavily involved in science ever since I was a freshman in high school. And I think I started off with big dreams. It sounds like a lot of you have a lot of big dreams and goals. And, I wanted to be a surgeon. I wanted to do research. I wanted to, start this institute, do translational research, and, have a family, all that stuff. And I think, unfortunately, as, I went through the pre-med track and then in med school and then residency, I found that a lot of my classmates, and myself included, we end up getting kind of disillusioned at some point. And it's a matter of when that is, but it's almost inevitable, unfortunately. And you realize, there's only so much time in the day, and that you can't get all these things done. For instance, I forgot who mentioned the goals of getting an MD, MBA, and being a dermatologist. That in and of itself is already really difficult. If you go to hospital administration after a few years, it's really rare and really, really difficult. I'm sure it can be done. Our hospital, our skill is actually a nurse, ironically, and there's a lot of politics involved in that as well. But anyway, so we all show up, in college and in med school with big dreams, big aspirations. A lot of, we go through a lot of hard work, and eventually, when you're out, especially at residency PT down and practice PT down as well, and you end up with dealing with a lot of insurance issues, which we didn't sign up for. I didn't go into medicine in order to fill out a lot of paperwork. There are all these articles now about getting that doctors are really paid on what you document and not what you actually do. So now we have the government telling us a lot of things about what you must document, what you must do, and that's really actually not why we went into medicine. We went there to help people, or to do research on the side, or as a main goal to kind of for the betterment of society. And you end up being told by administration or the government what you can or cannot do, about what, someone talked about psychiatry and social work, and now chiropractic. That's another sore point. I think a lot of psychiatrists or a lot of people go into psychiatry because they really want to talk to people. Ultimately, in our medical environment, psychiatrists don't have time to talk to people, so they end up being these kind of glorified drug pushers, and that has been a common complaint amongst most psychiatrists. I think the exceptions to that are maybe at Kaiser and maybe at the VA, but essentially they say here are your meds, and if you want to talk about your problems, you need to go see a therapist, because even though psychiatrists are trained in therapy, it doesn't reimburse well, it doesn't pay the bills, and they ultimately need to pay the bills or they cannot stay in business. I mean, medicine is a business, and unfortunately, just like everything else, it's not charity care. If we all were doing this and we want to work like 90 hours a week to do it for free, I mean, better really love it, or be like, whatever, marry someone who like founded Facebook or something. I mean, you have to pay the bills. So, and that's what's happened with a lot of my psychiatry friends. They that's not what they sign up for, but that's how it is, and that's the reality of it when it's all said and done. And unfortunately, I think the environment is rapidly changing. It's really hard to keep up. In my field, we're getting our reimbursements cut drastically every year by up to 20%. And I mean, no field does that. In no field would it really be okay to say like, oh, I made 20% less this year than the year before for 4 straight years. And it's just the way the government is now. There's only a certain amount of money, and our patient population is getting older. Once you get hit 65, they all have Medicare. Medicare only has a certain amount of money, and it's going bankrupt. So essentially, there's a huge pressure from the government, and it's squeezing out, every last dollar from doctors. In addition to telling doctors how they must practice, like you must have a mammogram if you're a woman over 40. Even if the woman declines it, that's a ding against the woman's record. That's a ding against the doctor's record, and it's actually recorded. Like, oh, therefore we're going to penalize you now. Or you must document whether or not your patient smokes, or unless they're a pediatrician. And if you don't do that, I mean, basically, like I said, the government is essentially telling us how to practice, and that it's actually been very frustrating. Less so for me as a radiologist, I don't actually deal with that stuff as much. But in patient care, they have to see patients, and they're getting paid less in order to see them for less time, and they have to do more and document more. And you're not paid for documentation. I mean, you must document, and that's what you're paid based on. But you're not paid for the time it takes you to document. These are a lot of kind of frustrating parts that have come into the healthcare environment, which I never envisioned. I mean, 10 years ago, I always said, why did I become a doctor? Why do a lot of people want to become a doctor? You feel like, it's a respectable job, you use your brain, it's a good living, it's stable, and you get to help people. And ultimately, what I've realized over maybe over the last 10 years is it's not as respected as it used to be, that's for sure, especially here, especially when you have people like you all who Google everything and come in and tell the doctor what you think you have. It's not well paid anymore, that's for sure, especially in fields like pediatrics, where Francis knows that the starting salary may not even break 6 digits. And when you're talking about 4 years of med school and at least 3 years of residency, you could get a job right coming out of Berkeley as an engineer and do that, right? As opposed to having like negative income for 4 years and minimal income for 3. We just want to look at the finances of it. In terms of using your brain, it is an art and it does use some brain, but eventually you're so pushed by time that it's kind of difficult to use your brain. You kind of just react, or you're forced by a company like Kaiser or by the VA to go by their guidelines. And you actually have a very difficult time of going outside your guidelines. Either that or you're in private practice and you say, oh, well, I read this paper and it says I should prescribe this drug. Oh, but you know what? That drug is not on my patient's insurance plan. We can't do that. So it's something else. And you end up like losing a lot of the flexibility in how, ideally you would practice. And finally, and probably the worst part is, you want a doctor usually to help other people. Anyone who says I want to do it to get rich, that's not going to happen. So you want to be a doctor to help people, and you realize you actually cannot help people. You can only help people help themselves. So if they want to be helped, that's great. But you can't tell like the obese, hypertensive, diabetic guy who smokes to stop all that. It will never happen. You are not their gatekeeper. If they want to go exercise, you can help them with that. If they want to control their blood sugar, so to give you an example, in med school, our clinic was next to a donut shop. We would have these diabetic guys come in with crazy blood sugars. And it's probably not the best place to have a donut shop, but what can we do about that? It's really the patient who chooses to do that. And, we can't punish them for that. And I think these are all a lot of sad kind of like realities that come out of our system. And they were actually all touched upon in the video. The one thing the video did not touch upon, I mean, the movie is the legal environment, which I think that I wish someone would do. I think that a lot of, they say doctors are paid like fee for service, and we get paid for what we do, and maybe that's not the best thing. It has to be some kind of hybrid where we have preventative care and you get paid for that, but also some kind of bonus structure for keeping people healthy and taking care of stuff. Fine. But the other problem is lawyers sue us for like $50 million and take a huge cut. So in a sense, like you should do the same thing with them. I mean, you want to sue and make $50 million for the patient, fine, but you only get $5 grand. But you don't get $5 million of that, or whatever percentage they get of that, and because of that, there's a huge practice of defensive medicine. Like, I'm going to over-order all these imaging tests, which come to me. Or there's like an over-treatment because they're worried that they're going to get sued by these lawyers. And actually, the worst case is in pediatrics or an OB. So, at least in our state, I don't know about where else, but kids or parents on their behalf can sue up until the age of 18 for anything that happens. So, say, something happened to the baby coming out of the birth canal, or like when they were 2 years old, they actually can go all the way to age 18 and say, like, you screwed up my kid. My kid's going to be like 60. So let's just say, now you owe me $1 million for every year. That's like $45 million. And because of that, malpractice insurance is extremely high. In our state, it's actually okay because we have limitation to damages. But to give you an idea, malpractice insurance for a neurosurgeon in New York or Florida, where there's no cap, is $250,000. So you actually have to make $250,000 just to break even and actually there's no law that requires malpractice insurance in those states where there is here. So a lot of them are like, well, you know what, I'm just going to just forget it. I'll just take my chances. It's like gambling. It's insurance, right? So I hope I won't get sued this year and I would have saved $250,000. But it's just a gamble. Like, so I assume maybe I'll get sued once every 10 years. So, and then how much that will be, I mean, it's really, that's essentially what the kind of the game has become out there. It's not as bad in California, but there is definitely defensive medicine, a lot of over-ordering of tests, a lot of over-treatment coming from lawyers. And then another problem, which I guess we have no control over, is our society, and we're kind of like a victim society, and that we kind of don't really take responsibility for our actions anymore. I think in the 40s and 50s, something bad happens, it's just like your mom slapped you, it's like you should have known better. But now when something happens, it's like, oh, it's someone else's fault. I fell in McDonald's and I saw like a yellow, slipper when wet, piece of Mojado sign, and I fell anyway. Oh, I'm going to sue you for, whatever, $30 million, even though that's not really worth that, And then I guess another example that I have is I see athletes. I mean, athletes are worth a lot of money. So, like, you mess up an athlete's knee or shoulder, and they're like, I had a contract for $30 million every year. Now, I don't have to retire. I'm going to sue you for a ton of money. And all these practices end up making medicine like a very kind of scary place to practice. That actually kind of paints a pretty negative picture of medicine. Having said that, I actually like my job. I use my brain. And I'm glad where I am. I started off in surgery, actually, and I actually used to be an orthopedic surgeon. I quit that 2 years into it, and I switched to radiology. So taking the path that I've taken, I do like what I do. I just think it's important to be realistic about where people stand with what they might do. There still are good fields out there. I think derm is definitely one of them. Orthopedics is one. My field was good. I think it might be good for a while longer, but I think it's definitely going downhill. I think if you look at a field like nuclear medicine, which you probably may never have heard of, it's for a reason. So they didn't manage their field well, and now they're basically all out of jobs, and they've been kind of basically, we've evolved past them in a lot of ways. And, I think about if I had to do it over again, or if I went to Stanford, or an entrepreneur, or whatever, and I'm kind of 50-50 on it. I do like what I do, but it's important to be realistic and understand what the field really is. And that it's like a lot of hard work, a lot of frustration for a lot of years. And then even when you're practicing, it can get better. Like I have a very flexible job. I'm a little bit more unique than others, though. And yeah, maybe I'll leave it at that for now.
Okay.
You guys have specific questions?
Thank you, Eric. That's actually a lot of stuff I wish I knew before I went to med school. But you have a lot of pre-meds here. Who wants to jump in first? Okay, Lebing, I see your hand up. So and Kate after that. So okay, let's jump in there, Lebing.
I have a question about financing medical education. I'm about to go to USC, and that's about $50,000 just for tuition per year. Is it? I was thinking about joining the military to help pay for basically my whole medical school. I was wondering if you knew anything about that, or if not, if you could give me an idea, if you don't mind, about how your financial situation played out and how long it took you to pay everything off and whether or not that was feasible.
I can tell you a little bit about. I don't know too much about that, but I know a little. So I personally didn't have loans, so I was fortunate enough to have my parents support me through college and med school, although I did go to a public med school for a reason. So that's that. In terms of the military, I mean, you're kind of beholden to them. So when you're done, I think you have choice on what kind of residency you want to do. You do not specifically have choice on if you can do a fellowship or what fellowship you can do. So you can get to the first step, but a lot of places, like, you really need a fellowship to do what you want to do. I think there are exceptions, like derm. You don't have to have a fellowship, or urology, you don't have to have a fellowship. But if you just become, like, do internal medicine, for instance, and you really want to be a cardiologist or GI, I think I'm not sure, the military has the right to say, like, no, we pay for it, we own you, you cannot do a fellowship. You owe us, I think it's every year, you owe them a year, right? So they could probably send you somewhere like Afghanistan or Korea or Japan or Germany, wherever it is, Alaska. I mean, they own you for 4 years. And then you can go to your fellowship, but you don't always have a lot of choice. Sometimes you do, but not always. So I do know people who were in the military because some of my co-residents were in it, and they wanted to do fellowships, and they said no, and they sent them away. And at that point, actually some were female and they were married, but it's like, this is what you signed up for. So family had to go. I think it worked out fine. So I guess it's one of those things that if you really don't have to, I wouldn't do it. If you really value the freedom of it. And it is very expensive. I mean, what you're telling me, I didn't know, it's $50,000 a year just for tuition. For 4 years now, we're talking $200,000, plus the opportunity cost. Say you work at a doctor, you need to go work a job that said, I don't know, paid like $80,000. Now we're talking about near $500,000 turnaround. It's really expensive. And I'm not saying money is everything, but I have a friend who went to Harvard with me, went to Cornell for med school. She's a urologist. She works at Kaiser. So she came out with $250,000 of debt. That's a huge hole. I mean, you don't come out and just bank like $1 million every year. Like, this is not the 70s, So it's tough, and it is something to be aware of. Yeah.
Okay. Thank you, Eric. Kate, do you have a question?
Yes. So, as a radiologist, what is your take on working with chiropractors? And since you were in surgery in the beginning, I don't know if it's back surgery or whatnot, what is your opinion about chiropractic care versus back surgery, or just this two?
This is a relative. So, I understand what the sentiment of what you were saying earlier. I think it's very struggle against essentially what the field has established itself as, and that is it's not like as academically proven as traditional Western medicine. And you definitely, there are patients who really believe in chiropractors, and they seem to have great results. But the chiropractors that I contact with tend to not be particularly kind of academic or even ethical in a lot of ways, unfortunately. I think I think there's room for that in our society, definitely. but it's kind of like an uphill battle, and you really need to prove yourself and also kind of strive to be like an example of what a good medical professional is. Because there's certainly bad professionals. In terms of radiologists, I've dealt with a couple chiropractic radiologists. They only read X-rays, I think. And I mean, I think they do an extra year of training. I think it's a profession, it's bad, but it's, I don't know. I mean, I have 6 years of training, X-rays and CTs and MRIs and all that stuff. And I did have the best experience with that. I actually almost worked with chiropractors in the imaging, and I eventually didn't like the way they ran the business. I think that, like I said, kind of typical answer, but it is kind of an uphill battle. But I think there's find your way as long as you do what's right, you know, and get like a rigorous education and study. I don't know if that answers the question.
Cool. Yeah, I think. Thanks for that the answer to that. Any other questions for Eric as far as Alan? I see it. Go ahead, Alan, please.
Hello? Can you guys hear me?
Okay.
Okay. I had a few questions actually. You mentioned insurance, basically insurance plan limiting your flexibility. Patients don't want to take care of themselves. Victim society, legal environments. Are there any other major pain points in being a doctor that basically impede the ideal of treatment? Like, people have, I know that doctors have this ideal of what they want to do, what they got into medicine originally to do, to treat people a lot, which I assume is pretty universal among most doctors, correct? What are barriers to that? What are the things that are stopping you from that? What constructs of society, of politics, of law, or whatever are stopping you from that? I'm just curious.
Oh, that's a really complex question. Number one is patient. The patient has to do what you say, really, and has to be on board with your plan. So one example is, in surgery, you think actually that's the easiest. You just operate and they're done. But you can't. You operate, but they still have to do what you say. They still have to do the right rehab. In terms of my field, where I was dealing with broken bones, they can't smoke because microvascular disease, they won't heal. They can't walk on it because whatever you put in there in front of fixation is going to fail. So we can do our best to help people, but they still have to help themselves. That's one. Two is insurance is a big problem too. So I actually had a major surgery. Insurance wouldn't approve it, and so it was just like a major headache. And then the doctor, again, so from my surgeon's point of view, same thing. He's like, look, I'll help you out, and he has staff to help me out, but like he didn't sign up for med school to be some kind of insurance social worker either. That's not his job either. Not my job as a patient. So, but I mean, it's got to get done, and it's extremely frustrating. And I actually know how to navigate the system, and it still took forever. In fact, my bill is still kind of in limbo, and it's been a year later. And I think it just kind of fell through the cracks, which is fine with me. But I mean, that's another with there. Which, by the way, so I had an outpatient surgery which took 3 hours, and they billed insurance $190,000, which and insurance will probably pay maybe 20-30 of that. So, that just also shows that our system's really screwed up. But I think, insurance is a major pain point for doctors that want to practice a certain way, that want to do a certain surgery or prescribe a certain drug or do a certain therapy, and that's not covered by insurance, or insurance will only cover part of it and the patient can't afford the rest, or even access. Like, this is one of those things, like, all you guys are probably in the kind of the same, socioeconomic demographic, but you realize when you're in a field like medicine that there's all sorts of different people you would never normally interact with, like that. homeless guy you step over at Berkeley, like that could be your patient. And like, oh, I'm gonna prescribe you like this anti-HIV retroviral. Oh, you know what? It costs $100 a day. I can't afford that. You know, he's like, not only can I afford that, I can't even like get on the bus to go to where I need to go to the pharmacy to get that. And you're like, well, is that my problem? I don't know. I mean, I just know what you gotta have these drugs. But ultimately, it's kind of, it is your problem, you know, or your problem as you and the patient together. There's a lot of other things that go into it. Like you can learn in med school. These are the drugs cocktail you take. This is what you got to do. But yeah, the logistics of it all, I mean, they're difficult. One thing that happened, I did surgery in Miami. So Miami has a lot of low-income people. We had these people get drunk, hit by cars, whatever. And then when we finally patch them up and they're ready to go home, they declare themselves homeless. Oh, I'm homeless. So you can't actually discharge a guy to the street. She has, you know, you can't discharge him back to being homeless. He has to actually go somewhere. But there's not infinite, you know, halfway houses and shelters. So essentially now, as a physician, I actually became this like social worker placement guy. I would have to like call my buddy at some like house, like, do you have room for my patient? And you know, I know a guy that knows a guy who might have a bed. It became like extremely difficult and painful. Again, I wanted to be a surgeon, not this guy calling my buddy at homeless shelters. But it's got to get done, right? It's patient care, really. You can just say everything is patient care. But yeah, I think those are two big pain points in our field: insurance, and then the patients themselves. Who actually, one thing the video was very good about, and the movie, was that it shows that patients need to take responsibility for their own health. It's not our job as physicians. It's their own job to take care of the. I mean, they need to go to the doctors and get checkups and you know, do a kind of self-rest exam or guys with testicular exam. You got to eat right. You got to control your own blood sugar. It's and exercise. Don't smoke. All that stuff. It is not anyone else's responsibility. You know, and it kind of goes for all of us as people.
Okay. Any other question? Oh, Alan, another question?
Well, okay, yep. Sort of a follow-up to that, I guess. You said that patients really need to take care of themselves. So, hypothetically, you're in a world where you basically don't care. Don't care is the wrong term. You are not responsible for patients outside of what happens inside your surgical ward. Would you actually just kick them out? Would you try to find better accommodations for them or whatever? I mean, there's a reason that there was an original reason why we have these laws passed or whatnot, because people were outraged when they saw this and they decided to do something about it. Now, whether or not that actually helps in the long run and whether or not it's helping now is a different question. But I'm just asking for your opinion right now.
Actually, I don't understand your question. Can you rephrase the first part?
I guess I'm saying, if you lived in a purely libertarian world or whatnot, where everybody was fully responsible for himself and no one basically needed, wanted, or was even allowed to care for other people besides social contracts or whatnot. Am I explaining myself right now very well right now?
Are you basically asking, Alan, that if we were in a world where we don't have to, we were only responsible for someone's health within our own sphere of control, right? Yeah. What would that actually look like in reality? And I think, and correct me if I'm wrong, Eric, that's pretty much what we live in right now. Is that I think a lot of doctors are trained to do medicine in one way, but and if we were given, and I'll speak for myself, my own experience, I would love to save the world in my own way, but there's just no way. There's just no way. There's only so much time in the day. There's only so much I know. There's only so much I actually do. But at least from what I'm hearing and what I'm understanding is there's so many bits and pieces of the puzzle that are missing from what we are as physicians actually are taught to and trained to do, that we kind of have to make do with whatever we have at that moment in our environment, and it's really up to us to try to, in on our consciousness as human beings and the role of physicians, to try to do as much as we can at that point in time. But I'll say this: I know for every decision I've made as a physician, that took away time for another decision I had to make for another patient somewhere else. Would you say that's the case, Eric, for you?
I mean, definitely. I think my field's a little insulated because most of the day I just sit in front of the computer and look at a bunch of X-rays and CAT scans and stuff. So once it gets to that's why actually I like my field. Sadly, a lot of people don't particularly like talking to patients. Surgeons, really, they like cutting, and radiologists, pathologists, we like a little separation. Pediatricians a little different. I think they love the kids, but they hate the parents. So, anyway, I lost my train of thought. But yeah, just leave it at that.
Okay. Does anyone else have a question?
Christy, I noticed you raising your hand earlier, or was I mistaken?
I know I was, and I was like, no, don't do it. But no, I think what you actually, Ellen, are bringing up is an interesting question. If you look at the healthcare industry as a whole, especially in the American public, we haven't decided yet if healthcare is a right or a privilege, if it's a public good or a private good. And I think that if that's something that interests you, the field of health economics, or even econometrics, if you want to really geek out, is something you might want to take a closer look into, because it really talks about the political science component of the industry that is exactly what Eric is talking about in terms of what physicians struggle with, is that physicians want nothing more than to provide incredible patient care and make their patients healthy, except that they're operating in this context of an industry where we don't even know, like in retail consumerism, we know that most everything's a privilege. But in healthcare, we're like, on the one hand, we're like, oh, it's a right, but we're not treating it as a right in terms of a good. We're not treating it as a public good. And so how we, I guess, commoditize healthcare has a direct impact on that day-to-day patient interaction and Eric and Francis's ability to really do what they want to do for that patient and with that patient. So that's all I had to say kind of about that one.
Cool. Thank you, Christy. Anyone have any questions? Yes, Dominique. I was just about to come to you.
Oh, us.
Oh, okay. Sophie and Dominique. Yes, please.
Do you want to ask? We can both ask our questions. Yes. Oh, I was just wondering what kind of, we're talking about how deeply entrenched this system is. What kind of changes would we need to even start to make, to really transform the system? Would it be through, policy? Would we go, through the government? Would it be something, we as consumers need to make a conscious decision about? Or, what do you think, having been in this field for so long? Do you think it's possible to change it? And if so, what do you think we should do? What are the first steps?
Oh, that's another huge topic. It probably needs to come from all directions, and people talk about a healthcare revolution. So I think it needs to come from the top down, from government, with and lawyers, but also from every person. And again, and you talked about whether or not health is a right or privilege. I think it's actually, that should actually be directed towards an individual person. Is it your right or I guess privilege to be healthy yourself? And so I think everybody needs to take responsibility for their own health care, and actually everything in between. The whole system needs to be overhauled. And I don't know what the answer is. I'm Taiwanese. They talk about the Taiwanese system a lot, but that's going bankrupt. look at Canada. I actually know Canada's system okay because I did my residency up in Seattle, so I know a lot of Canadians. But they have a lot of problems with their system too. And then other issue that doesn't work in the United States is that we have such a heterogeneous population and a lot of people who are not even necessarily citizens, so they don't pay taxes. So they're essentially kind of getting free care, and how are we going to pay for that? So, a state like I'll work in Sweden, where like pretty much everyone is kind of blonde and blue. It's not, and small, right? It's like the size of a state. It's not going to work for something the size of the United States. It's so big, it's so heterogeneous. So I don't know the answer to that, but I do think it'll definitely start with tort reform, with lawyers, and with individuals taking more responsibility for themselves. Yeah.
Thank you.
I also had a question too. So it does sound like you do have like a background knowledge of what is going on in our healthcare today, and because you work as a doctor now, you are a physician. What I wanted to see what your opinion was about the Obamacare, and I know we asked Christy before as well, but I mean, what is your opinion, or can you kind of tell us what that general consensus is when it comes to physicians, thinking about the healthcare in the future? And I ask this because it's really interesting. Because I mean, it's a great. I think it's a great thing that he has going. Except there's just so many things that are wrong with the healthcare now that it just seems like you try to fix one thing and then there's another roadblock, and then you try to move that, and then you know what I mean, right? So, what's your opinion on it, or what would you say the general consensus is, like within like the physician world?
Yeah, so I think I'm kind of conflicted. I mean, no one is going to argue that people should not have cheap healthcare and health insurance. So, having said that, I think the medical community is divided. Primary care people who actually don't care about money, and we're talking about people who are already working on Indian reservations in inner city ghettos, and I mean, they really work because they want to help people. They all love Obama and think, the universal health care is great. Because they see what happens when people don't have health care. Like, they die, and they get really sick, and it's horrible. But, everyone else, maybe it's kind of mixed, because it's basically going to drive our incomes really low. And there's only a certain amount of money. And you can say, like, for instance, one analogy is driver's insurance. Not everyone drives, but the vast majority of people drive. So it's required that you have driver's insurance, right? But, not everyone does. And what happens when you don't? You're just like, sorry, my bad, I don't have it. What do you do about it? It's the same thing. And that's what's going to happen, I think, with universal health care. You're required to have it. Okay. I don't have it. What are you going to do? Not treat me? I mean, and that's the thing, like, where physicians are actually, in a sense, outside the law. Like, we don't follow the same laws as everyone else. We must treat you. We cannot dump a patient, even not in the ER. If it's for a religious reason or whatever, like, you must find that patient another doctor to take care of, or you must take care of them. And for whatever price, it could be zero. It could be negative. If they don't pay you, you're using resources and time and actually losing money on that patient. And they can still sue you. So these are kind of, I think it's mixed. I think, like I said, family practice, rural care, like underserved, they all are in favor of Obamacare. The subspecialists, probably not, because it's just going to cut off all of our pay a lot.
Right, because I asked you that because you did mention that you were a surgeon, and also by 2014 over 400 million Americans are not going to have healthcare coverage, right? And so it's like it just didn't make sense economically to me, where there was a surplus and yet the demand is so high, except the supply is extremely low. You know what I mean? And none of this makes sense. So I just wanted to just kind of see what you guys thought about what was happening.
Just because you require healthcare doesn't mean it's going to be cheap. So, I mean, it's called Affordable Care Act, but I mean, I don't know if you guys actually know how much you pay in healthcare. So when I worked for a a private group, my healthcare insurance actually costs $600 a month to not even use it, right? And it still deductible on copay. So we're talking over $7,000 a year just to have it, and not use it. My current is like what a lot of people are on. It's a high deductible plan, and it's gone up by over 50% in the last 2 years. So, I mean, and that's me, and I'm young, and I don't have any problems except for my knee. So if you look at anyone who has any kind of problems, they're going to have expensive healthcare, really expensive healthcare. And they may just say, forget it, I'm just not going to have it and go there and pay the penalty if that ever happens. So I'm not sure exactly what will happen. But I would say most of the higher income physicians are against it because we're already getting cut at all levels, and this is worse. Basically, the idea is that we're going to cover more people, which is good, and we'll treat them, which makes us busier, and so we'll have higher volume, but we'll get lower pay per volume, significantly lower. Because the volume was always there. Those people would always be sick. Yeah.
So there's even less incentive, because med school's so hard, and then you come out extremely in debt, and then you get a cut to your pay. So that just really sucks too, I guess.
Less money every year.
Right. Okay. Oh, and then I also had a second question. Sorry. So, do you use a lot of, I guess, within the hospital, now people are kind of like pushing for that, like the new age technology, like not only with hospital instruments, but, just like, HIPAA compliant, hospital, like on an iPad tablet where you like doctors can keep tabs on their patients or like look at X-rays and stuff. I mean, would you say you are one of those doctors who actually implement that kind of technology? What's your opinion on that whole, that new age technology coming into the hospital?
Radiologists are much more like technologically savvy than most doctors.
Right.
So I do keep on top of that.
Good job.
And
yay.
went from computer all day, and like for instance, EMRs sound all great, but they take a lot of time. And unfortunately, it's a business. Like I said, everything comes down to time, and time is money, just like that. So if it's like, oh, we should have EMRs. Who's going to pay for that? It's not free. EMRs cost like $300,000. So if you're like a solo practitioner, you have 5 people in your group, you're going to sit down and do a business meeting and like, hey, how much does paper cost? It's like what, 0.2 cents per piece of paper, or we can buy this $300,000 EMR, which you cannot bill for. You get nothing. I mean, there's no ROI on as you never get your money back. You just do it because it's either going to be required by law. I mean, and I think Obama is requiring EMRs, but it takes actually much more time, as you guys know, to like type out a paper or whatever, even if with voice recognition software, which is not perfect, than it does to just like scribble some stuff down. So implementation and adoption of technology is very slow for that reason, just for money. And also it takes time. And actually most doctors are like these old guys who don't like technology. Actually, you'd be surprised at how many of these doctors don't even have smartphones. They don't want to adopt new technologies. And then actually one other thing that I worry about with EMR is data mining by lawyers. Because now everything is digital. They can just search anything and be like, oh, you said no instead, or you said right instead of left. Like, that was a typo. Whatever. It's on the record. That's a legal document. And they can hire some high school grad for like $10 an hour to comb through all your stuff. Whereas with paper records, that was much more difficult to do. So I worry about like this huge thing of lawsuits that's going to come in the future. Actually,
Thanks.
Very cool. Okay. We have about... Oh, I am not stuck here. Okay, can you guys hear me? Alright, so we have only about a few minutes left. We have time for one more question. Otherwise, I would like to thank Eric here for his time and giving us the doctor's perspective. Did you have another question, Alan, or was that it? Alan, do you have a question?
What?
Yep.
Okay. I was just slightly morbidly curious, actually. Christy, do you have a response to what was just said.
Oh,
Given
so
that you actually did work at EMR.
wait, we got for about 4 minutes. So yes, a quick abbreviated response, if possible,
no, I've
to
been brought into this big debate. This is great, actually. No, it's great. I think the answer is we're seeing everything. I mean, in complete honesty, we're seeing everything. We have large academic systems that are able to use extremely sophisticated EMRs that can turn a bigger buck and have a better ROI and improve patient care and improve, cut back end billing people so that it actually adds to their bottom line. We have small independent private practice docs, as Eric said, that it's very difficult. There are certain models, some of you may be familiar with, like Practice Fusion and other free EMRs out there. The challenge with those is that they are, they're supported by advertising revenues, embedded ads, kind of like Gmail type model. But for example, the type of work that you do in radiology, it may not be tailored to that. It may have limitations in terms of interfacing and everything. So it's kind of similar to corporate America, where right now the big guys, the big fish, are able to use it to their advantage, and it's undermining, I guess, the little fish in the pond. So the federal government is making a lot of strides in the ONC to kind of level the playing field, so to speak, but we're still pretty early on in seeing what all the outcomes are in those regards.
Cool. Thank you very much, Christy. I think that's pretty much all time we have time for. I'm gonna send email out to everyone so you can get Eric's contact information as well too, just like we'll do with Christy. Eric, once again, thank you so much for your time and sharing some of your experiences, insights, and as parts of your journey, and giving people a preview of what the associated pre-meds, what they will probably have at least some exposure to throughout their whole experiences of becoming physicians. Obviously, as you guys go down there, Eric will probably give you some more advice and also insights of what he's gone through during his whole journey as you guys advance through your careers as well too. So, once again, I just want to say thank you everybody for coming to these talks. Thanks again, Eric, and thank you again, Christy. And all you guys, I will be emailing all you guys with their contact information. So, thanks again, everybody.
Thank you.
Have a good night.
Good night.
Bye.
Thank you.